Assalamu alaikum everyone. My name is Dr Sulhera Khan and I am a postgraduate trainee at Medical Unit 3 Jinnah Postgraduate Medical Center. I am honored to be a part of the Pakistan Society of Hepatology and glad to have my article accepted for the oral presentation at the PSH 2022 conference, Lahore. The topic of my presentation this time is incidence, grading and mortality of acute and chronic liver failure according to the EASL CLIF criteria. The authors of the study are myself, Dr. Professor Syed Masroor Ahmed, Dr. Zishan Ali Zunejo, and Dr. Mariam Wakar Fatma. Introduction. Acute and chronic liver failure is characterized by acute decompensation of liver in patients with pre-existing chronic liver disease. The condition presents as jaundice, deranged INR, or extrahepatic organ failure resulting in early death. It is seen that ACLF triggers a cascade of systemic inflammatory response, hence we need to utilize liver failure adaptive organ assessment scores such as European Association for the Study of Liver, Chronic Liver Failure, EASL CLIF criteria to grade these patients. These scores fluctuate with the daily changes in the lab parameters during hospital stay. Despite this, the patients will usually have a clear prognosis between day 3 to 7, which helps guide the specialist for further management. The study was a prospective cross-sectional study carried out for 6 months at Jinnah Postgraduate Medical Centers, and all patients who consented for the study with chronic liver disease were accepted. However, the patients with major comorbidities such as hepatocellular carcinoma, renal replacement therapy, congestive cardiac failure were excluded in order to remove the bias from the study, and the patients who denied consent and patients with missing data were also excluded. According to the EASL CLIF criteria, the grading of ACLF is as follows. We divide them into two groups, that is non-ACLF and ACLF. The patients without ACLF are considered those who do not have any organ failure or those who have a single non-kidney organ failure, whereas the grade 1 ACLF is where we have renal failure or single non-kidney organ failure, patients with single failure of liver, circulation, coagulation or respiration with a serum creatinine level of 1.5 to 1.9, our patients with mild hepatic encephalopathy. Grade 2 ACLF is where we have 2 organ failures, and grade 3 is where we have 3 or more organ failures. The EASL CLIF consortium organ failure scoring system states that the bilirubin levels in the liver is greater than 12 mg per deciliter, the serum creatinine is greater than 2, or the patient is on renal replacement therapy. The patient presents to us with grade 3 or 4 hepatic encephalopathy. The INR is greater than 2.5. There is the use of vasopressors, excluding those who are using it for HRS, and the SpO2 and FiO2 is less than or equal to 214, or there is a need for mechanical ventilation. The results of our study state that out of the 148 participants in the study, we had 29.1%, that is 43 participants who met the criteria of ACLF. The overall mortality was 20.1%, that is, and 23 participants, and it was seen that majority of the mortality was in the grade 3 ACLF group with almost 100% participants, that is 6 participants expiring, with 0% mortality in grade 2, 16.57% in grade 1 and 12.4% in non-ACLF group. Out of all the organ systems involved, it was seen that renal failure was seen in 60.5% of the participants in the ACLF group, followed by cerebral failure in 46.5% of the participants. We had 66, that is 45% females, with 55% of males. According to the grading, ACLF grading, EASL CLIF criteria, we had 105 participants in the non-ACLF group, followed by 24 participants in grade 1, 13 in grade 2, and 6 participants in the grade 3. With the CTP scoring correlation with the ACLF, we saw that the participants in non-ACLF and ACLF grade 1 presented to us with category B of CTP scoring system. However, the patients with ACLF grade 2 and ACLF grade 3 presented to us with the CTP scoring category C. The association of ACLF mortality with the organ failure, it is seen that majority of the participants presenting to us in the ACLF group presented with renal failure, followed by cerebral failure and the use of vasopressors. And however, it is also seen that the participants in the non-ACLF group did not have renal failure, and majority of the participants in the non-ACLF group were presenting to us with cerebral failure, 23.8%. For the conclusion, it is important to identify ACLF and differentiate it from the mere decompensation, as management and prognosis of both groups differ significantly. It is seen that the patients identified early with 2 or more organ failures at presentation can be planned for aggressive management and early liver transplant to reduce the mortality. This is the reference slide, and thank you for the presentation.